Okay, well, we are in for a treat. Dr. Cook is a very energetic speaker. He is a returning, he's one of the most favorite speakers for this course, and will also be speaking to us tomorrow on EKG pearls for the boards and for your practice.
That sounds wonderful. Oop,
Oh,
perfect. Here we go. Oop. Okay. Thank you, Ananth. I appreciate you. It's always great working with you. And audience, hopefully I'll give you some great pearls and maybe a few questions right on your boards. My name is Mike Krug. I'm a general internist. I have no disclosures. I did take all these topics that I'm going to present to you directly from the stated areas of focus in the ABIM exam blueprint. So hopefully they have good yield for you. We're going to jump right into questions. And of course, this is audience response. And as Ananth noted, please type anything that you like in the Q&A, and I'd be happy to respond in real time. So first case, 56-year-old man who is in the hospital has acute onset of dyspnea and chest pain on hospital day number 7. He's being managed for cholangitis related to advanced pancreatic cancer. He's on ampicillin sulbactam, cholecalciferol, subcutaneous heparin, Megace, and sertraline. His vital signs you see there, he's got some tachycardia and he's hypoxemic, 93% on 5 liters. He's tachycardic, his lungs are clear. Woo! He's got no edema of his legs. His platelet count on admission was 200,000. Now it's 65,000. His creatinine is stable at 1.6. CT angiogram reveals an acute pulmonary embolism. What will you order? Here's time for the audience response. A heparin drip, low molecular weight heparin subcutaneously, a direct thrombin inhibitor like bivalirudin or dabigatran, or an IVC filter to be placed immediately, or mechanical thrombectomy. Put those nickels down. What would you pick? In this case is based on a real life case, actually, that I was involved in. Okay. It's sharing. Okay, great. So the correct answer here is C. So I think only a third of you got this one right. So what's going on here? So indeed, this person does have a pulmonary embolism, so we've got to anticoagulate. But the difference here is this platelet fall. So remember here at the bottom, near the bottom of the screen, the platelet count on admission was 200,000. Now today it's 65,000. So this patient has HIT, heparin-induced thrombocytopenia. And some people say give it a second T, HITT, heparin-induced thrombocytopenia with thrombosis. And that's what this patient has. So I need you to think, I implore you to think about heparin-induced thrombocytopenia in any inpatient who has progressive thrombocytopenia or who has a thrombosis. This is a high risk setting for HIT because we treat most of our inpatients with pharmacologic thromboprophylaxis with heparin or low molecular weight heparin, so we're at elevated risk for it. And then often their inpatients are there for a few days, so they have enough time to develop it. So inpatients do develop HIT. So to remind you, the typical platelet count fall is greater than 50% with a nadir greater than 20,000. So that's perfect for this case, right? 212,000 down to 65,000. That's more than 50%. And then they stopped at 60,000, which is more than 20,000. The onset is usually between days 5 to 10 of exposure to heparin. You can also get it from low molecular weight heparin. So this patient was day 7. And then thrombosis is common, but not necessary for diagnosis. So if you're getting progressive thrombocytopenia in the hospital and they're on heparin or low molecular weight heparin, ooh, you better think about this. And certainly if they thrombose in front of you, there's a significant chance in the hospital that this is HIT. Okay. All right, how do we treat it? Of course, you stop throwing gasoline on the fire, you discontinue the heparin, and then you fully anticoagulate with a non-heparin anticoagulant. So this is whether you have a thrombosis or not, right? If you just have the platelet going down, you think it might be hit, you check the assays, it's positive, you anticoagulate those people, because if you don't, they have a 53% chance of getting a thrombosis within 30 days if you don't anticoagulate them. In this case, of course, they already had the clot, so of course you're going to anticoagulate. So you can do some of these lesser used IV options in the acute setting. You can use fondaparinux, or you can use basically any DOAC. All right, next case. 35-year-old Army lieutenant who lives in the barracks presents with the acute onset of headache, neck stiffness, and photophobia. No past medical history. He does have a penicillin allergy listed. His mom told him that he had an allergy. He doesn't know the details, but he doesn't think it was an anaphylactic event. He's on metformin. He's febrile. He's tachycardic. He's fatigued and ill appearing. He's alert and oriented, but a little bit sluggish in his responses. He's got clear meningismus and no other focal neurologic deficits. Lumbar puncture is performed. He's got 3,500 white blood cells, mostly PMNs. Gram stain shows gram-negative diplococci. What would you recommend for treatment? A, moxifloxacin, B, rifampin, C, full-dose ceftriaxone, D, ceftriaxone via test dose procedure, E, pretreatment with glucocorticoids and antihistamine, then ceftriaxone at full dose. All right, need a couple more. Okay, there we go. Okay, so the correct answer here is C. Most of you got this one right, a few not, so I'll be a little bit quicker in the explanation for this one. The correct answer is full dose ceftriaxone. So of course this patient has meningococcemia, right? Army barracks is classic, meningismus, gram-negative diplococci on their lumbar puncture. So they've got meningococcemia. So glucocorticoids, remember, we use for pneumococcus. That may help mortality, but in this case, meningococcus, you don't need to use the steroids. So really, it's this person has a listed penicillin allergy. It sounds kind of weak, low risk, pen fast. Do we pull the trigger on full dose ceftriaxone, or do we wimp out and use moxie? The best answer is ceftriaxone. It's the treatment of choice. It penetrates the CSF well. This person has a serious condition. That's what we got to do. So to remind you, penicillin allergy is reported by 10% of patients, but only 1% of patients actually have a true IgE-mediated allergy. So that's 10% of those who report the allergy. Among those who have that, there's a less than 10% cross-reactivity with cephalosporins and a less than 1% cross-reactivity with carbapenem. So in this case, penicillin allergy using a cephalosporin, unlikely this patient has it, and then if they had it, less than 10% chance they would react to the cephalosporin, carbapenem even less. You can use skin testing when it's available. It's almost never available. Certainly not in the hospital urgently. So if your patient has a true history of IgE-mediated reaction, anaphylaxis, hives, urticaria, angioedema, wheezing, or if they have a delayed type 2 to 4 reaction like serum sickness, DRESS, Stevens-Johnson, obviously you're going to avoid penicillin and you're going to be wary even of a cephalosporin or a carbapenem. You might do a test dose before this because those are the real deal. This is the uncommon patient, the 1%er who actually has had an IgE-mediated or delayed reaction. If they're lower risk, like they just had a maculopapular rash, not hives, or they're not sure what happened, their PenFast score is low, treat them with the cephalosporin or the carbapenem. It's extremely low risk. If you're going to use a penicillin, you might think about a test dose up front. And of course, if they just have an intolerance, you're going to give the penicillin. So if you're not aware of the PenFast, it is awesome. This is another way of systematically risk stratifying your penicillin allergies. So thinking about our patient, it's been more than 5 years since his reaction, so that would be 0. He did not have anaphylaxis or angioedema or a severe cutaneous adverse reaction, so that would be no 0. And he did not require treatment that that we believe, so that would be no. If you have any of these, if you have a score of 0 to 2, it's low risk. If you have greater than 2, it's moderate to high risk, and you should be more cautious. Next case. 72-year-old man presents with spreading redness on his left shin for the past 2 days. He scraped his shin 4 days ago on the edge of his deck where there was a nail head and frayed wood. He's got type 2 diabetes. He's got hypertension. He has a history of peptic ulcer disease. He takes insulin, metformin, amlodipine, HCTZ, and omeprazole. On exam, he's febrile. He's tachycardic. His blood pressure is 101/50. He's saturating well on room air and not tachypnic. He's uncomfortable, but he's lucid and clear. On his skin exam, he's got a 10 by 10 centimeter area of, maybe like that, 10 by 10, confluent erythema and induration over his left lateral shin and calf. And when you touch it, it really hurts him. Oh, man. His labs, white cell 18,000 with mostly PMNs, hemoglobin 11, sodium 126, BUN 30, creatinine 1.9, glucose 380, CK 900, CRP is 130 milligrams per liter. The upper limit of normal in your lab is 20. You will start this patient on IV antibiotics and IV fluids, obviously. What else would you do diagnostically? A, surgical consult. B, MRI left shin. C, ultrasound left shin. D, Doppler ultrasonography of the left lower extremity. Or E, tetanus serologies. Okay, about 7 out of 10, 70% got the right answer, A, surgical consult. I can understand why you'd pick C and D, but that's not quite as good as this top one. All right. This person has the dreaded necrotizing fasciitis, flesh-eating bacteria, NSTI, necrotizing soft tissue infection. I prefer flesh-eating bacteria, but some of these other ones are perhaps more professional. This person has an NSTI. How are you going to figure that out on the boards and in real life? Well, give me one sec there. They're going to have cellulitis, and then there's going to be plus. They're going to have severe pain, right? Cellulitis is usually uncomfortable, but not horribly painful in my experience. If they give you crepitus, that's a gift. They're telling you there's gas-forming organisms under the skin. That's high likelihood going to be necrotizing fasciitis. Signs of skin necrosis, if you see that, or rapid onset of sepsis, right? If things are progressing fulminantly, you're worried about a toxin. In this case, the toxin from the bacteria in those fascial planes. It's often the extremities. It sometimes is the perineum, so-called the eponym Fournier's gangrene. There is no obvious portal of entry in about 50% of the cases. In this case, there was the nail, but sometimes it just pops up. And the patients always tell me, I wonder if it was a bug bite or a spider bite, but sometimes this just pops up. How do you treat it? You need surgical exploration and debridement, IV blood spectrum antibiotics, including something that suppresses the toxin like clindamycin or linezolid. So looking back at the case, this person has signs of progressive sepsis, fever, tachycardia, borderline hypotension, severe pain with palpitation, and then the labs are amok, right? These are septic, advanced sepsis labs, hyponatremia, anemia, high CRP, hyperglycemia, etc. There is this scoring system, the Lorinex score, many people look at to help risk stratify NSTI, and this person's would be sky high because of all these values. It has like sodium, creatinine, CRP, glucose, etc. Okay, next case. 44-year-old woman presents with nausea, vomiting, and confusion. Her friend thinks that she took a bunch of pills. She has a history of depression. She takes amitriptyline at home. On exam, she's afebrile, heart rate 80, blood pressure 135/70, respiratory rate 35, oxygen saturation 99% on room air. She appears ill. She's oriented to your 3 questions, but otherwise she's pretty confused. Doesn't quite know what's going on. Her affect is odd. You do check her reflexes, and for ankle clonus, both are normal. No clonus. ABG 7.47, 23 for PCO2, 90 for PO2. Here's her set of labs. Sodium 135, potassium 4-chloride 100, bicarb 17, so that's low. BUN 12, creatinine 0.9, glucose 90, anion gap 18, that's high. AST, ALT normal, alk-phos normal, bilirubin, albumin normal. You do check an EKG, normal sinus rhythm with normal intervals. What is your diagnosis? A TCA, tricyclic antidepressant overdose. B, serotonin syndrome. C, anticholinergic overdose. D, salicylate overdose. E, acetaminophen overdose. See if we can get one or two more responses. Okay. All right. Best answer here is D, salicylate overdose. Many of you got this one right. Let's review why. So this person has this arterial blood gas, 7.47, alkalemia, PCO2 23. So they're overbreathing. This is a respiratory alkalosis. However, they also have a concurrent metabolic acidosis as indicated by their bicarb being 17. Normal is 24, there's 17, that's an acidosis. And then if you recall, the anion gap was 18. So the sodium minus the chloride plus the bicarb, the difference there is 135 minus 117 is 18. So they have an anion gap metabolic acidosis and a respiratory alkalosis with tachypnea. That pattern is either two processes going on or salicylate toxicity in the setting of ingestion, which is the case here. So I didn't give you tinnitus. That would have really helped you. But this pattern suggests salicylate poisoning. All right. So yeah, again, tinnitus. If you hear tinnitus in an overdose situation, the answer is going to be salicylates. It can also cause nausea and vomiting more commonly. You can diagnose it with a serum salicylate level. Those come back quick. They're part of the general overdose panel, and you're going to treat with sodium bicarbonate to alkalinize the urine and hemodialysis to get rid of it in severe cases. All right. So a refresher on the toxidromes, which they love to test. And you're like, I'm not an ER doctor. And they're like, too bad, you need to know the toxidrome. So serotonin syndrome, altermentation, plus clonus, tremor, or hypertonia. So remember, I gave you that in the STEM. The patient had normal reflexes and no clonus. They should have some of those for serotonin syndrome. Anticholinergic overdose. This is the mad as a hatter confusion, dry as a bone, so dry secretions, red as a beet flushing, blind as a bat mydriasis, hot as a hair fever, or full as a flask urinary retention. Those are the anticholinergic overdose signs. This patient did not have those. Salicylate overdose, we talked about this, tinnitus, and then the respiratory alkalosis with anion metabolic acidosis. Acetaminophen overdose, hepatic injury. Of course, if the person just swallowed them, you may not see it then, but it shouldn't cause this confusion that this patient was having up front. Tricyclics or the acid-base abnormalities. Tricyclics can cause anticholinergic symptoms and cardiac conduction abnormalities, namely a widening of the QRS, which is why often we avoid prescribing TCAs to patients who have depression with a history of suicidality because they're more lethal than the typical SSRIs, SNRIs, the TCAs, because of that cardiac conduction side effect at high doses. Okay, next case, rapid fire here, right? 75-year-old man with a chronic non-healing diabetic foot wound that is worsening despite wound care. He denies fever or chills. He has type 2 diabetes with neuropathy and nephropathy, no recent infections. He's afebrile, but vital signs are normal, basically. He's in no acute distress. He's got a chronic appearing left lateral fifth toe, so pinky toe ulcer with open tract. You can see it. Ooh, man, there's like a whole wound. It goes to the bone. You can see that when you probe in there. A small ring of surrounding erythema, no pus noted at the moment. ESR and CRP are elevated, white count normal, creatinine 1.5. You get an MRI, it suggests osteomyelitis of the left fifth toe. You maybe didn't even need that because of the exam, but you got it. Microbiology, wound swab shows MRSA sensitive to Vanco and methicillin sensitive Staph aureus, MSA, sensitive to vancomycin, cefazolin, TMP-SMX. Blood cultures, no growth to date. What would you recommend? A wound vac, aka negative pressure wound therapy. B, surgical debridement or removal of the toe. C, IV vancomycin and piperacillin tazobactam for 2 weeks. D, IV cefazolin for 2 weeks. E, oral Bactrim or TMP-SMX for 6 weeks. I don't see the Ananth, I may be missing it, but I'm not seeing the poll pop up. Or Sharon. And if I screwed it up, I apologize. There we go. Thank you. What do you guys think? Okay. Thank you guys for your continued participation. I know it's a lot of questions in the day. All right. B is the right answer. 70% of you guys got it. Surgical management. Very good. Yep. Yeah. So, when you've got osteomyelitis that didn't come through the bloodstream infection, right? So contiguous osteomyelitis, in this case from a diabetic foot wound, the best way to diagnose it is a bone biopsy. The best way to culture it is a bone biopsy with culture. And the best way to treat it is to debride it or take away the toe. So it's all surgical. And sometimes you don't see this done in practice because of other considerations, desire to try to save the toe, inability or unavailability of a surgeon to get the biopsy, etc. But ideally, this is all surgical. For the boards, it is surgical. Antibiotics are an adjunct, right? So if you just debride it, okay, you're going to need antibiotics. If you clip the toe, you're only going to need a couple days of antibiotics, right? You've solved the problem. And then wound swab cultures do not correlate well with bone cultures. So if you have the option to get a bone culture, you're always going to want that for more refined, accurate antibiotic treatment regimens. So again, this is non-hematogenous. If you've got a bloodstream infection, let's say you've got endocarditis and then it's seeded, let's say the spine or what have you, then the treatment can just be IV antibiotics. That's the way it came in. But if it came in through a superficial ulcer or something like that, then the treatment is surgical. Great. Okay. Next question. 73-year-old woman presents for pre-op clearance for a knee replacement, elective knee replacement. She denies dyspnea or chest pain. She's able to climb 2 flights of stairs and do housework like mopping floors and raking leaves without trouble. She can only walk 2 blocks though because of her knee pain. She's got coronary disease. She had a CABG in 2007. She had a stroke in 2014. She's had type 2 diabetes for 17 years, hypertension, obesity. She's on aspirin, insulin, metformin, atorvastatin, carvedilol, lisinopril, furosemide, gabapentin. Her vital signs are normal. She appears well. She does have obesity. Her other exam is normal. Her ECG shows sinus bradycardia with no ischemic changes. What will you recommend? An echocardiogram, a treadmill EKG stress test, or maybe a bike because of her knee, a radionucleotide nuclear medicine stress test, a cardiology consult, or no further cardiac testing needed? You guys are rock stars. Thanks for your continued question answering. And here, let me switch back to this just so you see it. So remember pre-op clearance She can do some exertion. She's got a lot of comorbidities and a normal EKG. Next time I'll flip back and forth a little more, but let's stop this one here. Okay. All right, 70% get every one of my questions right. The right answer here is E, no further cardiac testing needed. And I'll explain to you why. Okay, of course, if someone needs an emergent surgery or they're going to die, then you're probably going to need to just do that surgery and take risk, right? This happens actually pretty often, right? Like in the setting of hip fracture, right? A patient falls and fractures their hip. This needs to get repaired urgently, maybe not emergent, but in the next week or so. And so the calculus is different. You know, they may have some trouble, but you're going to try and get that done. And if it's a true emergency, life-threatening, then you're going to get it done. All right. Have they had worrisome cardiac symptoms, right, where you would work that up anyways? Or have they had a coronary event in the last year? Ooh, that's high risk. You're going to get cardiology involved in that, if at all possible. If they have low cardiac event risk, less than 1% based on surgery and patient factors, then you're okay to proceed, because even if, you know, if their risk is 0.8, and even if you can get it to 0.75, if you do some things for 6 months, like, yeah, that's probably not worth it. You're going to move forward. But then if you get to here and they're higher than 1%, then you can move to exercise tolerance. So if they have moderate or better exercise tolerance, the scoring system du jour is the DASI, Duke Activity Score Index, or a poor person's version is the metabolic equivalence, or METs. If they can tolerate 4 METs or have a DASI over 33, they're good to go for surgery. They don't need any coronary stress testing. If they're not that, then you're in this dreaded gray zone where you can consider a stress test if you think it will change management. Many providers would not do a stress test for this patient, but a minority, I think, would. So for our patient, it's not an emergency, it's an elective knee. Does she have worrisome cardiac symptoms? No, you asked, she doesn't. Has she had a coronary event in the last year? Nope, it was in 2007 she had that. Does she have low cardiac event risk? I'll just tell you no. You know, her scoring system will give her higher than 1%. Does she have moderate or better exercise tolerance? Yeah, she can go up the stairs, she can rake, she can mop. She's more than 4 METs. Her DASI is going to be close to that, so she's going to proceed. Okay, don't order a pre-op cardiac stress test unless they have worrisome symptoms that you would work up anyways, or they're very risky, it's a high-risk procedure, and they can't exert at least 4 METs. What is 4 METs? A couple flights of stairs without stopping, walking 3 to 4 miles an hour, walking uphill 1 to 2 blocks, scrubbing floors, moving furniture, mowing yard with a push mower. Oh yeah, doc, I mow my lawn all the time. Well, what is it? Oh, it's on this like tractor that I ride around. That doesn't count. But if you use a push mower, that counts. Bowling or tennis, right? So 4 METs is moderate exertion on the scheme of things. What about a pre-op echo? What do we do with that? Well, if they have signs of worsening CHF, or worsening valve disease or symptoms, you should get an echo. If they have moderate or severe pulmonary hypertension or moderate or severe valvular stenosis, then they need an echo within a year. And of course, if they have known CHF, I guess not, of course. If they have known CHF, but things are not going right, they're escalating the doses of the diuretics, they're still trudging along, they're still more dyspneic, they're having PNV, something like that, then you should get an echo within a year. So we're ordering way more echoes in the peri-op setting these days than we are stress tests because of these criteria. Yeah, bowling, isn't that crazy? I mean, maybe people work it up, you know? Well, you got to roll it first and then you got to do your dance when you get the strike. So maybe that's the added exertion. But yes, bowling classifies as 4 METs. And I think, honestly, if the only way they got it was the bowling, to me, I'd definitely ask some clarifying questions. Like, what are you doing when you're bowling? Are you like rolling it down the kid thing? Or are you like rolling up and going through it? And if they're rolling up and going through it and walking there and back, apparently that's 4 METs, especially in the right setting. Thank you for that question. All right, 51-year-old is post-op day 6 from reconstructive right knee surgery. Not the same patient. Reconstructive knee surgery after a traumatic injury to the knee. So this person sustained trauma. It was a motor vehicle crash. They needed urgent reconstructive right knee surgery, and that happened 6 days ago. You were consulted due to acute kidney injury. Inpatient, the patient taking vancomycin, phenytoin, ondansetron, atorvastatin, and morphine. Vitals here are pretty normal, heart rate 95. Patient is pleasant, a little bit uncomfortable because of the knee. The knee is bandaged, it's tender when they move the knee, and there's clearly bruising and swelling around the ankle distal to the knee. Labs, sodium 133, potassium 4, chloride 100, bicarb 22, BUN 42, creatinine 1.7. So that's why you got consulted, right? New BUN up to 42, creatinine up to 1.7. Urinalysis, the dipstick shows blood. The microscopic urine exam shows 3 to 5 hyaline casts per high powered field, 2 white blood cells per high powered field, 0 red blood cells per high powered field. What will you order to help establish the diagnosis? A, urine eosinophils. B, urine protein to creatinine ratio. C, serum creatinine kinase level. D, serum vancomycin level. E, Doppler ultrasound of the renal arteries. I'll pop back in a moment to the stem. Stay on this for a few seconds and then I'll go back. Okay, what do you guys think? Okay, thanks, guys. So somehow 70% didn't get this one right. It's the first time. The right answer here is C, serum creatinine kinase level. And I'll go through why. All of your other answers weren't crazy, right? This person's on new antibiotics, new medications. Could they have an AIN? Could they have vancomycin toxicity? Do they maybe have worse chronic kidney disease than you thought? Now they're nephrotic or something like this. All these answers are okay, but the best answer here is C, is serum creatinine kinase level, and I'll tell you why. Pardon me. Whew. Okay, this person has rhabdomyolysis. That's why the CK is the right test. What is rhabdo? Muscle cell death, right? The muscles get either killed by a toxin or overexerted or crushed in this case or squeezed. They release muscle products into circulation. That myoglobin floats around, causes trouble, especially in the kidneys. Yeah, so again, in this case, it was due to muscle trauma from the initial insult and then the surgery. It can also be just drugs and meds, like statins with a drug-drug interaction. Symptoms: myalgias, weakness, red or brown urine. This person didn't have that brown urine or red urine to really tip you off. And then the lab findings can be illustrative. You know, a new AKI in the hospital, you're generally going to get a urinalysis, and then this can really show you something. If the dipstick is positive for blood, like in this case, right, the dipstick can be fooled by myoglobin. So in this case, the dipstick was like, there's blood in this pee. But then the microscopic exam where they looked at the urine and looked for red blood cells showed no red blood cells. So that's a tip off that it's myoglobin turning your dipstick positive for blood. But then there's no actual blood that you can see in the microscopic evaluation. So that's suggestive of myoglobinuria and rhabdomyolysis. What else do you get? You of course get a CK that's very high, at least 1,000, often in the tens to 100,000 plus, and then acute kidney injury with associated electrolyte derangements due to a toxic effect of the myoglobin hurting the kidneys. So, again, to go back to the stem, if you look at the bottom here, the dipstick was positive for blood. The microscopic urine exam had no red blood cells. And then, of course, certainly the story is consistent with rhabdomyolysis, right? Reconstructive knee surgery 6 days ago. There's still tenderness of the knee. There's swelling and bruising, some muscle damage, rhabdomyolysis. I mean, you might also get a Vanco level, sure, make sure you're not showing other trouble, but this stem really points towards rhabdomyolysis as the cause of this AKI. Okay, next question. 23-year-old woman from Estes Park, Colorado, presents with 1 day of escalating fevers, malaise, and a rash that looks like a sunburn. She has no headache, no neck ache, no photophobia. She's had all her vaccinations. She's healthy, doesn't take any meds. On exam, she's febrile 39.1, tachycardic 135, hypotensive 82/40, tachypneic 24, saturating 90% on room air. She doesn't appear well. She looks ill. She's tachycardic, chest is clear. She's got a diffuse red macular rash over trunk, upper and lower extremities, including her palms and soles. Lab, she's got leukocytosis, mostly PMNs, hyponatremia, AKI, transaminitis, urinalysis is normal. Chest x-ray shows no acute processes. You start her on IV antibiotics and IV fluids, of course. What will you do next diagnostically? A, comprehensive skin exam looking for ticks. B, lumbar puncture. C, take a sexual history. D, pelvic exam. E, echocardiogram. And I'll toggle back to the stem for those that like that. Okay, thank you all. You guys are rock stars to hang in there and keep answering these questions. This is a tricky question. Um, it's nuanced. The best answer here is D, pelvic exam. Many kudos to the 2 out of 9 of you who got that. Very impressive. This is a tricky question. A is not a bad answer, but not correct in this case, and we'll walk through why. Okay, this person has toxic shock syndrome. The reason for the pelvic exam is looking for a retained tampon. What is this in this case is staphylococcal. You can also get streptococcal. Um, what what are the symptoms of toxic shock syndrome? Rapid onset sepsis. This person clearly has it. Normal the day prior, fulminant sepsis on presentation with multi-system organ failure, malaise, AKI, transaminitis, starting to get hypoxic and diffuse macular rash resembling a sunburn that involves the palm and the soles. This person had this. What's the epidemiology? 50% are menstrual, hence the pelvic exam being the right answer. 50% are non-menstrual, so like a surgical wound infection, a postpartum wound infection, sinus or respiratory infection rarely, skin infection rarely. Treatment, remove a tampon if it's there or anything else that's in there. Remove a tampon from the nose. Rarely you can get it from that. And debride surgical postpartum wounds, and then IV antibiotics, including clindamycin or linezolid for toxin production. So now you're saying to me, well, what I thought Rocky Mountain spotted fever had the rash in the palms and the soles. It does. And actually, unfortunately, the rash involving the palms and the soles has a significant differential. I was hoping it'd be like two things, right? Like then I can just file that away. If it's this, it's this. Unfortunately, Rocky Mountain spotted fever can cause a rash involving the palms of the soles. Secondary syphilis can do it. Stevens-Johnson's can do it. Measles, mumps, rubella, and hand-foot mouth disease can do it. Meningococcemia can do it. Erythema multiforme, usually drug reaction, can do it, and toxic shock syndrome can do it. So unfortunately, it narrows down a little bit, but not as much as I would hope. I don't think I have it in me to remember seven, a differential of seven. I think like three. But anyways, toxic shock syndrome is on there. Rocky Mountain spotted fever is on there. Rocky Mountain spotted fever is, of course, one of the worst misnomers in medicine. This is the case distribution list in the U.S. You see here, it's in sort of like the mid east or whatever. I don't know what you're going to call it. Not quite south, not quite north, but east. And of course, the Rocky Mountains are over here, closer to us, right? Like here's Colorado, here's Utah, these are the Rocky Mountains, are not that they're that far. So it was mean of me to make this case set in Estes Park, Colorado, which is the home of Rocky Mountain National Park. But anyways, I try to make a point. Rocky Mountain spotted fever, not generally in the Rocky Mountains that much. All right, next case. 53-year-old woman with cystic fibrosis was admitted 8 hours ago with recurrent pneumonia. You're called because she's since developed agitation and flushing. She has cystic fibrosis, depression, alcohol abuse. She's on linezolid, piperacillin, tazobactam, promethazine, citalopram, acetaminophen. She is febrile. She is tachycardic. She is hypertensive. Respiratory rate is normal, saturated 92% on 2 liters. That's what she was saturating before because of her pneumonia. She's agitated. She answers questions, but it's kind of disoriented. Her pupils are dilated. She's hyperreflexic. She's got clonus at her ankle. She's flushed. What's your diagnosis? A, Redman syndrome. B, neuroleptic malignant syndrome. C, malignant hyperthermia. D, serotonin syndrome. E, alcohol withdrawal. And I'll go back to the stem for a moment. Okay, and here's the question and answers possibilities. Okay, yep, the right answer here is serotonin syndrome. Most of you got that. I gave you a little teaser on this earlier. And now, they say spaced repetition in adult learning, right? I gave you the teaser, now it comes back. Maybe it'll even come back again. You never know. But yeah, this is serotonin syndrome. Clonus, hyperreflexia, can have fever, flushing, tremor, agitation. I gave you like all of them in this one. This is a little bit of a gift. What meds, they have to be on something serotonin, serotonergic, and then you usually need a second hit, like an insult that will cause this. It doesn't usually start from starting a typical dose of something serotonergic. It's usually when something else happens. So what's that second hit? It can be a stimulant, MDMA, and amphetamines. It can be another obviously serotonergic agent like a triptan, ergot, or buspirone. An MAO inhibitor, that's classically when this used to happen all the time, when we used to prescribe MAO inhibitors for depression 20 plus years ago. And then if you have multiple reuptake inhibitors at once, like if you had tramadol or ondansetron, it can cause this. The other thing is look out for sneaky MAO inhibitors. Like linezolid and tadalafil antibiotics actually have MAO inhibitory effects. Rasagiline or selegiline for Parkinson's disease are MAO inhibitors. So this is where I've seen it lately. In the last 10 years, the times I've seen serotonin syndrome have been from linezolid and from selegiline or rasagiline from Parkinson's disease being added to other serotonergic agents. Second hit, they develop serotonin syndrome. So remember that clonus and hyperreflexia, and remember the second hit, and that linezolid and rasagiline and selegiline are MAO inhibitors and can precipitate that. Okay, so again, toxidromes. I'm reiterating this because I think it's so frequently tested upon. The yellow is like if you're like, gosh, I can never remember these. I can only remember one thing. Okay, well, clonus and hyperreflexia is your one thing to remember for serotonin syndrome. And the treatment is to remove the offending, is basically supportive care and stop the offending agents. Neuroleptic malignant syndrome, if you remember one thing, it's rigidity in the setting of some of these other things that are cross toxidromes. And again, remove the offending agents, supportive care. Anticholinergics, remember we talked about earlier, red as a beet, mad as a hatter, hot as a hair, blind as a bat, full as a flask. Remove offending agents, supportive care. So it's mostly these are important so that people take off the offending agent, because if not, that could be very morbid or lethal. Okay, next question. 63-year-old is admitted with chest pain and dyspnea. Vitals are pretty close to normal. Blood pressure is 106/56. Appears well. Normal heart cardiopulmonary exam. Does have pitting edema of the left leg. Okay. Troponin is normal. BNP, so that's the B-type natriuretic peptide. That's not a basic metabolic panel, is normal. ECG shows sinus tach. Imaging shows a saddle pulmonary embolism from the bifurcation extending into the right and left main pulmonary arteries. Unsurprisingly, with that, the Doppler ultrasound of the left leg shows a large acute left femoral vein, DVT. Echocardiogram shows mild left ventricular hypertrophy. What will you recommend for treatment of this PE and DVT? A, systemic thrombolytic therapy with TPA. B, mechanical thrombectomy of the pulmonary arteries through IR. C, an IV heparin drip. D, an IV heparin drip plus an IVC filter placed. Or E, warfarin therapy. I'll switch back in a moment to the stem. Okay, very good. Thank you guys. You guys are showing amazing resilience and grit. I know it's a long morning. I do think it's going to help you. It helped me. Okay, the right answer here is C, heparin drip, and we'll talk through why. Okay, this is important. They love to test this because it's very clear in the guidelines that this is what's supposed to happen. Okay, based on how severe your PE is, here's what you're going to do. If they are hemodynamically unstable, defined as systolic blood pressure less than 90 or other signs of advanced shock despite IV fluids, right? So they get a bolus first. Then you do systemic TPA and then anticoagulation after that. Okay? That was not the case with this person. Remember, they had a normal blood pressure and they didn't have other signs of shock. So they don't get TPA. Intermediate risk, what is that? Well, they're normotensive, no shock after the fluids, but there's evidence that that blood clot in the lungs is backing up and causing strain on the right ventricle. That's intermediate risk, aka submassive PE. So what is that? So that's either right ventricular strain visualized on echocardiogram or on the CTA itself. They can calculate these ratios and tell you that, or a positive troponin or a BNP, right? So I'll take you back to the stem to convince you, but this patient had none of those. I'll answer your question in a moment. Thank you for that. This person had none of these issues, right? So if it's intermediate risk, then sometimes you would do thrombolytics or mechanical thrombectomy case by case. But in this case, this patient had none of these. So if they don't have hypotension, they don't have RV strain, they don't have a troponin positive, they don't have a BNP positive, you're going to anticoagulate alone. And the question is, if a DOAC's available, would that going straight to it be the right choice? Great question. Thank you for answering. I'll tell you, I think it would be totally reasonable in this case. Yes. I think in practice, many people treat up front with a heparin drip because then if the patient worsens, like if they worsen into submassive or get hypotensive, then you can turn off the heparin drip and give the lytics or do the mechanical thrombectomy. If they swallow the 10 milligrams of apixaban and then 2 hours later they get hemodynamically unstable, now you cannot give thrombolytic therapy because they have anticoagulation already on board, which is an absolute contraindication. So that's the reason we often use a heparin drip up front if you're worried the patient may devolve into massive PE and needing thrombolytics. Thank you for asking that wonderful question. So again, to prove to you, So again, this person's blood pressure is 106 over 56. Okay, they're not hypotensive. They don't need thrombolytics. What about, are they in the medium zone where I think about it? Well, their echo did not show our right ventricular strain. Their troponin was normal. Their BNP was normal. So they're lower risk. And then someone's saying, well, but it looks terrifying. There's a saddle pulmonary embolism. I know that's bad. What's true? That is, saddle pulmonary embolism does have slightly worse prognosis than non-saddle, but it is not a reliable enough marker that we should be more aggressive with therapies. We should decide on aggression of therapy based on blood pressure and signs of RV strain. I'm reading the question. Based on the old PE classification than the new. Andrew, help me out. Let me know what you mean, and then I'll answer that. I'm not sure what you mean by the new ones or the old ones. Hook me up. You might teach me. I'd really appreciate that. So for saddle pulmonary embolism, 22% develop hemodynamic instability with an overall mortality of 5%. So it's not as high as you might worry. And that's why we don't do thrombolytics for all patients just based on what the imaging looks like. We do it based on what the blood pressure and then what the signs of RV strain are. Good. IVC filters are the devil. Do everything you can to not put one in at all times, in real life and on the boards. So the main indications for an IVC filter placement: one, a proximal VTE with contraindication to anticoagulation, which this person did not have. Or two, a proximal VTE with progression of the VTE despite anticoagulation. So we usually don't just put one in because we're worried about the clot progressing despite anticoagulation. It's usually, oh, we can't use anticoagulation, therefore we need an IVC filter, with rare caveats. You are teaching me, Andrew. I am not sure. I saw the chest guidelines recently, and they're very similar to this, but maybe there's something hot off the press. So I'll have to not. I don't know. I don't know the answer to your question. Sounds like maybe there's some new ABCDE with respiratory modifier for severity of PE and then treatment. I don't know about that. So you're probably ahead of me. All right, next question. 74-year-old with a history of pulmonary embolism 3 years ago is planning for knee replacement surgery. They take warfarin. Maybe they have antiphospholipid or something. So you're like, why are they on warfarin? But they do, and they take lisinopril. What will you recommend for perioperative anticoagulation for this patient? Stop the warfarin at 5 to 7 days prior to surgery, no bridging. Stop it and bridge with low molecular weight heparin. Stop it and bridge with apixaban. Place an IVC filter, stop the warfarin, and then stop the warfarin. What do you guys think? Okay, excellent. Thank you guys for sharing and answering. Good. The best answer here is no bridging. Oop, I messed up the sharing. 64% got the right answer A, 36% chose B. The best answer here is definitely A, and we'll go through why. Okay, so if you're on a DOAC, right, you're on apixaban, rivaroxaban, edoxaban, dabigatran, you're never going to bridge that because the half-life of the bridging agent, low molecular weight heparin, is basically the same as the DOAC anyway, so it doesn't provide you any additional benefit. So don't bridge a DOAC. If you're on warfarin, a vitamin K antagonist, then you occasionally, I might say rarely, bridge based on the history of their thrombotic risk. If you have AFib, or if you've had a single blood clot, DVT or PE, and it's been more than a year, you do not bridge. The annual thromboembolism risk is pretty low on that. The risk of holding it for a week or two is low. You're not going to bridge. If you've got a super high CHA2DS2-VASc of 5+, if you've had recurrent blood clots, if you've had a blood clot within the last year, if you've got a high risk thrombophilia or cancer, or if you've got a mechanical valve, then maybe you bridge. And then if you've had a clot in the last 3 months and you're on warfarin for that, or if you have a certain type of higher risk mechanical heart valve, then you do bridge. So in a nutshell, most of the people that we see do not would not benefit from bridging their warfarin unless they are like obviously higher risk, right? Recurrent clots, clot in the last year, mechanical heart valve, these things. Then you either may or should bridge and never bridge a DOAC. All right, how are we on time? Ooh, we're running low on time. Team, should we do this one? I think we can skip this one because I want to summarize. This is a case of a patient with septic left knee arthritis, and I want you to treat it and drain it. Don't just treat septic arthritis with antibiotics alone. You want to treat it and then drain it also to get all that pus out of there. And you may even need a surgical washout to fix that. Great. Got to drain the joint for septic arthritis. So severe joint pain, when any movement of the joint, it's either blood, bacteria, or crystals. I call it a BBC joint. Hemarthrosis, septic arthritis, or crystal arthropathy. All right. So throughout this 60-minute talk, I've already given you a few things to think about in the realm of infectious. You got to ensure infectious source control, especially in the hospital. So from this talk, we talked about necrotizing soft tissue infection, flesh-eating bacteria needing surgical debridement. We talked about osteomyelitis. When it's non-hematogenous spread, the best diagnosis and treatment is surgical. We talked about toxic shock syndrome, removing the tampon from the nose or the pelvis, and then also debriding surgical wounds. And we talked about septic arthritis, draining the joints briefly. I didn't talk about other abscesses, right? If you've got a perinephric abscess and empyema, if you've got a catheter-associated UTI, a catheter-associated endocarditis, bloodstream infection, hardware-associated infection, the nidus has to be removed. So be on the lookout for niduses of infection during your boards, and then how you might achieve removing those or mitigating those to cure your infection. And here's the answer key. I will stop there in case there are any last questions. Thank you, guys.
All right. Thank you so much, Mike. I'm sorry I had to step away, but
You're good.
got through a lot of cases and a lot of really, really good questions from our attendees.
Absolutely. Yeah, well, I think this has got to be like the third or fourth time you've hosted this, or maybe more. So no sweat if you stepped away. I think you know all the answers anyways.